I think it's working. Okay, so this is going to be a quick excerpt of a mechanical support in respiratory failure lecture we gave, predominantly talking about BiPAP. And we're going to run through a case. All right, so the case, we got a 78-year-old female presents to the emergency department with confusion, shortness of breath. We're talking about next steps. What are the things we want to do now? Anybody that shows up with just a little bit of info and they're confused, and you got an x-ray that shows hyperinflated lungs, you need to be thinking about COPD, some version of obstructive lung disease. So we're going to be talking about getting a blood gas, chest x-ray, blood gas. Those are going to be highest yield at this point. Yes, the altered mental status, shortness of breath workup is ginormous, but that would be, first things first. So let's say you get a blood gas back, you get a hypercapnic blood gas, the CO2 is high, the pH is low, they're a little bit of metabolically alkalotic, which kind of goes along with some chronic hypercapnia. We get an ideal body weight of 50 kilos. Vital signs are okay. They're talking, but they're a little confused or off. They're dyspneic, they're wheezing. Physical exams otherwise okay. Labs, other imaging, we don't really care about. That's not the point of why we're here. Yes, there will be a lot of other things that you can do, but this would be kind of a decent start. Where do we want to go from here? What would we want to do now? Could put her on oxygen, but oxygen wouldn't be the next best step. Oxygen would just improve the O2 sat, which you do need, but you need some CO2 clearance. And remember, just putting her on O's will not improve her CO2 clearance. So we'd be talking about BiPAP or AVAPs, some version of mechanical support that would allow for CO2 clearance. You could even make an excuse for intubating someone at this point. I would say that is the wrong answer, though. We've got mortality benefits and improvements with BiPAP or non-invasive positive pressure ventilation of some kind. So that would be kind of what I think should happen next. And I think that would be agreed upon by most providers at this stage. So let's say we put her on BiPAP. This is just to kind of give us what we're looking at on the screen. Do we like to see? What do the numbers mean? So remember, her breath rate is 26. Right here, you can see that. The set rate is 12, so she's breathing above that, which is what we want. You want someone that has an intrinsic rate to breathe at their own desired rate. You don't want to be pushing this rate up super high to overcome their set rate. That's getting a little dangerous. You can lead to a little more air trapping, those type things. Tidal volume ends up being pretty good. Minute ventilation is pretty good. Peak inspiratory pressure is 10, which is very similar to the inspiratory positive airway pressure, which is 10. Remember, for BiPAP, you have inspiratory positive airway pressure and expiratory positive airway pressure. Remember that EPAP is very similar to CPAP or PEEP. That is just the base pressure, the pressure that is felt all the time. Your IPAP is above that pressure, so the EPAP would be at 5, the IPAP would be at 10, so the pressure support would be 5. So the difference between the two, which is the pressure support, would be 5. For this amount of pressure support, this patient is getting a tidal volume of 500, which is pretty good, which just means they're probably small, they're not obstructing, they have pretty compliant lungs, or something else is going on. And we go through the rest of this. I time this just how long the inspiratory effort lasts, at least per the machine. If they continue to try to inhale over that, it'll at least provide some support. How much oxygen they're on, the rise is kind of an irrelevant number, but it's just how quick they get to that peak pressure. The patient is triggering 99% of the breaths because it's only set at 12 and they're breathing 26, which makes sense. And then the total leak. Total leak here is very, very, very high. So anything over 34, 35 is considered high per the manufacturer of the machines here. 24 to 34 is kind of considered moderate. Realistically, you can probably clear enough CO2 with a leak of 34 to just let things ride. But a leak of 100 is way too much. This just essentially means that all the tidal volume they're getting is leak. There's going to be very little actual tidal volume that is being delivered here. And that's kind of what the numbers mean. So if we were to repeat a gas with these settings, with that amount of leak, we wouldn't expect that tidal volume that it says that they're getting to actually be real. The machine would probably be alarming and saying that there's a lot of leak. And we can see the blood gas got worse. So CO2 went up and pH went down, secondary to essentially just too much leak. So the goal here would be improving the leak, which can be done a lot of different ways. Improving mask fit. This is the lady, so I doubt she has a big beard, but if she had a beard, potentially shaving her face. What else would we have? Improving how she's sitting in the bed, just getting a new mask. Maybe she needs a smaller mask. Maybe she needs a bigger mask, the hockey mask, the full face mask. There'd be lots of different options here. So the reason it is worse is because the leak is too high. Make the leak better, and you will likely improve the patient. So let's say you just change the mask and everything works perfect. You didn't have to adjust anything else. Blood gas gets better. Patient does well, moves on with life. So again, leak too high, won't clear CO2. You want the leak as low as you can get it, which is predominantly determined by mask fit / seal.